Welcome viewers. In today's session, we are going to learn about the parietal bone. The parietal bone is a pad bone. It forms the major part of the superolateral aspect of the cranium, and it is one of the bones forming the neurocranium. It's a roughly quadrangular shaped bone. It has 4 borders, 4 angles and 2 surfaces. Being a pad bone, how to identify the side of a given parietal bone? The lateral surface is convex. So, this is the convexity on the lateral aspect of the parietal bone. It fits into the concavity of the palm of the hand. Now, this is the anterior inferior angle. So, this is the position of the parietal bone. So, this angle is the anterior inferior angle. When we observe the internal surface, we can make out there are impressions made by the branching pattern of the blood vessels. These are nothing but the middle meningeal vessels. Particularly, this is the antero-inferior angle where it articulates with the other 3 bones forming the bony landmark pterion. Anterior to that will be the squamous part of frontal bone. Antero-inferiorly, the greater wing of sphenoid, and inferior to this area, squamous part of the temporal bone. At the point of pterion, the anterior division of middle meningeal artery. From the pterion level, the stem of the middle meningeal artery, you can see it runs upwards and laterally, and the branches are running upwards and backwards. This is the anterior division, this is the posterior division. All these branches are running upward and backward. So, with this we can identify the side of the parietal bone. So, this given bone belongs to the right side. Let us see the external surface of this. The maximum convexity of the parietal bone, this is called as parietal tuberance. And during the intrauterine life, this is very important clinical point. The distance between the right and the left parietal tuberance is measured to assess the growth of the fetus. That is called the biparietal diameter. There are 2 temporal lines. The temporal lines start from the zygomatic process of frontal bone, then runs over the frontal squamous part, and then over the parietal bone, and then go posteriorly towards the mastoid. The superior temporal line, it fades away at the posterior end, but the inferior temporal line, it will be continuous with that of the supramastoid crest. The superior temporal line limits the depression inferior to it, that is called temporal fossa. The superior temporal line gives attachment to the gallia aponeurotica and also the temporalis fascia. The temporal fossa, entire surface, it gives origin to the temporalis muscle. The temporalis fascia is superficial to that muscle. The inner surface of the fascia also gives origin, and the muscle takes origin from the inferior temporal line also. The anterior border forms in articulation with the frontal bone, the coronal suture. The posterior border articulates with the squamous part of occipital bone forming the lambdoid suture. The superior border articulates with the other side parietal bone forming interparietal suture, otherwise sagittal suture. The inferior border articulates with greater wing of sphenoid, squamous part of temporal bone, and the mastoid part of the temporal bone. Each angle is also named. Prior to fusion of these, the bones which are in articulation, they are all known as the fontanelle. The antero-superior angle prior to 1.5 years of age without articulation with the other bones forms the anterior fontanelle. After the fusion, the same area, the bony landmark becomes bregma. Antero-inferior angle before 6 months of age is known as sphenoid fontanelle, and after the fusion articulation with the other bones, it forms the bony landmark pterion. The postero-inferior angle is the mastoid angle before 6 months of age. Prior to the articulation fusion of these bones, it was called as the mastoid fontanelle. Postero lateral fontanelle. After the union of these bones, it forms the asterion. The posterior superior angle before 6 months of age, prior to the union of these bones in articulation, that area was known as posterior fontanelle. But after fusion, it becomes lambda. In the parietal bone, 3 to 3.5 centimeters anterior to the lambda, adjacent to the sagittal suture, an opening in the parietal bone, that is the parietal foramen. Parietal emissary vein passes through it that connects the vein of the scalp extracranially and the superior sagittal dural venous sinus that gets lodged in the sagittal sulcus intracranially. On the internal surface, these are the impressions made by the middle meningeal vessels. The middle meningeal artery is a branch of first part of maxillary artery. After entering through the foramen spinosum, the artery divides into two branches, anterior division and posterior division. The anterior division runs very closely related to the point of pterion and runs upward and laterally. The branches are running backward. The posterior division, which is also known as parietal branches, they also run upward and backward. Each angle of the parietal bone is closely related to the vascular structures. Antero-inferior angle is related to the middle meningeal artery. Antero-superior angle is related to the superior sagittal dural venous sinus. Posterior-superior angle also is related to the superior sagittal dural venous sinus, and the posterior-inferior angle is related to the terminal part of the transverse dural venous sinus, which will continue as the sigmoid dural venous sinus. The injury to the point of pterion, though the injury may look blunt injury, by the force of the injury, the middle meningeal vessels can tear internally. Outer to the dura mater, the bleeding may occur, the blood clots, and that swelling becomes extradural hematoma or epidural hematoma that can compress upon the brain tissue. The person may go in for a condition of shock. Sometime later, the person may regain the consciousness, may be talking relevantly, normally to other people, but if not recognized well and if not treatment given appropriately, and that person may go in for continuous bleeding inside, the increasing amount of extradural hematoma can cause sudden death. That is called talk and die syndrome. The parietal emissary vein, through that the infection of the scalp can be transmitted in a retrograde way into the superior sagittal dural venous sinus. Along the superior border on the internal aspect is the sagittal sulcus. Being lodged in that is the superior sagittal dural venous sinus, and the lip of the sulcus gives attachment to the attached border or the superior border of the falx cerebri. Antero-superior angle forms the bradma, posterior-superior angle forms the lambda, antero-inferior angle forms the pterion, and posterior-inferior angle forms the asterion. Anterior border forms the coronal suture, superior border forms the sagittal suture, posterior border forms the lambdoid suture, and the inferior border forms the squamoparietal suture, parietosphenoidal suture, parietomastoid suture. The sagittal suture is an example for sutura serrata. The lambdoid suture is an example for sutura denticulata. The squamoparietal suture is an example for sutura squama, and this blunt injury with a force can cause depressed fracture. This is the left-sided parietal bone. The inner aspect of the left parietal bone we are able to observe. From the antero-inferior angle, the anterior division of the middle meningeal artery runs upwards and the branches are running backwards. The superior border is, so this is in relation to the sagittal sulcus. The superior sagittal dural venous sinus runs or gets lodged along the sulcus. The lip of the sulcus gives attachment to the attached border of falx cerebri, and these are the small pits the impressions made by the arachnoid granulations. So these are also known as the granular foveolae. The arachnoid granulations, they help to drain the CSF into the superior sagittal dural venous sinus. The posterior-inferior angle is related to this sulcus, which is at the terminal part of the transverse sulcus, and then which is going to be in continuation with the sigmoid sulcus. The transverse dural venous sinus will continue as the sigmoid dural venous sinus. The parietal bone is a flat bone. By development, it is a membranous bone, otherwise dermal bone. Dear viewers, thank you. Happy learning.